Good morning, I'm Guy Parr, I'm the CMO from Genry. This is a summary of the talk that I gave to the Underwriters last week at the Asisa Academy. The first section will be on a summary of looking at health and disease and looking at the ways that we analyze our approaches to illness. And then the second part of the talk will be on diseases of the gastrointestinal tract. The first thing I think one wants to think about is that our concepts of health and disease have changed quite dramatically in the 20th century. Perhaps 100 years ago, one was grateful to be alive, and when people got sick, they generally died quite quickly. Today, our concepts of health have changed quite dramatically, and people are really looking ahead and saying, how can I make myself healthier than I have been before? And we are finding a whole lot of new illnesses, sometimes non-existent illnesses are diagnosed, and we are also seeing a great deal more chronic illness than before. So our ideas of health and disease have changed quite substantially. We're finding that the illnesses that were present in the past, the infectious diseases, overall are less important, and as the availability of food increases and the body mass index of the population goes up, we're seeing many more illnesses associated with obesity and metabolic diseases. The group of people on the left there are the ones who would be seriously unlikely to have any metabolic diseases, whereas the individual on the right is all too common in our insurance practice. We need to understand that mortality globally from infectious diseases has reduced quite dramatically, as this slide would show. A lot of this decline in infectious diseases has been because of improved socioeconomic conditions, although contribution of antibiotics and new medicines has also had an impact on this. But you'll see from the graphs here that the decline in infectious diseases occurred long before the introduction of vaccines, or long before the introduction of antibiotics. Thank you. And our diagnosis and of the causes of disease in the 20th and the 21st century have changed largely from infectious diseases to diseases of aging, metabolic diseases, obesity, smoking, drug abuse, alcohol, sexual behavior, and increasingly in developed countries, more and more psychiatric illness is occurring. So in the developed community, the spectrum of illness is changing quite dramatically. Thank you. South Africa has an unusual mixture of causes of illness, and it's seen historically as having a high burden of infectious diseases, which reduced somewhat in the second half of the 20th century, only to rise again with the advent of HIV/AIDS. So currently we have a very high risk of communicable diseases, infectious diseases, tuberculosis, AIDS particularly. We also have a very high and increasing risk of non-communicable diseases, and these are the diseases associated with metabolic conditions, diabetes, hypertension in particular, obesity related. Certainly there's a dramatic increase of these illnesses throughout the whole of South Africa. Currently they estimate that nearly 50% of South Africans are overweight, and this is what's driving this increase in metabolic disease. Thirdly, to add to this triple burden of disease, we have a very high death rate from trauma. Not only road accidents, but also social trauma and homicides. And this particular grouping of illness has a substantial impact on the insurance industry. Although a number of the people who would be involved with HIV and TB may fall below and outside of the insurance group, we're increasingly seeing people with these illnesses within the insured population. Thank you. Okay. This is the distribution of mortality in South Africa, and you'll see from this that infectious diseases like HIV are very high on the list. Other infections would certainly include tuberculosis. You'll see cardiovascular disease is very high on the list, and you'll see injuries are particularly high on the list. And these certainly nationally, are important to us. Have the next slide. Okay. Compare this to the mortality figures for somewhere like Australia, another southern hemisphere continent, similar climate. We share some similarities, and you'll see that their spectrum of disease is completely different to South Africa. So we have really quite an unusual situation in this country, and as insurers we need to understand that our problems that we see in this country are very different to other countries. Thank you. Okay. One of the important changes in the late 20th century was the development of this concept of evidence-based medicine. In other words, which basically means you've got to have hard data. Just as in a court case, it's no good saying, well, I think this is what it's about. Any good lawyer or judge will throw that out and say, show me the evidence. And increasingly, we're obliged to show the evidence that things really work, or that the causes of disease are what we say they are. There's got to be hard data underlying our approach to illness. Thank you. The evidence-based underwriting is important because, certainly according to our constitution, we cannot discriminate against anybody unless we've got good evidence that that discrimination is fair. And fair to the individual we're discriminating against, and fair to the remainder of the people in that insured pool. Thank you. This slide shows very briefly what they call the levels of evidence. In other words, when we're looking at evidence-based medicine, how sure are we about what we think is the truth regarding health and disease? And the column on the left-hand side gives the levels of evidence. In other words, how sure are we of our facts, from level 1, which is really we're very sure, to level 5, where we think that's the case, but we're really not totally sure. And then stemming from that, the column on the right-hand side gives the recommendations following from that. From recommendation A, which says this is pretty hard data, this is what we should do, to recommendation D, well, we think it helps, we're not sure. Thank you. Okay. And this follows up from there, so we can pass on from there. Thank you. Okay. Important from this slide to realize that normal values are an average. They don't cover everyone in the population. They cover an average group of healthy people. Thank you. Right. Normal varies quite dramatically. As you'll see from this picture, 3 healthy athletic men, all very different shapes and sizes, but all perfectly normal. Thank you. Okay. When we look at underwriting particularly, we have to decide what tests we're going to do to try and establish our client's risk of certain illnesses, largely the cardiovascular and metabolic illnesses. And it's important when we do any of these tests to understand that these tests have limitations. They have their benefits, but they also have their limitations. We'll continue with that, please. Keep going. Thank you. And all of these are important when we look at any tests we do at an underwriting level, blood tests, ECGs, chest x-rays, whatever it is that we do, lung function tests, we need to understand the risks and the disadvantages of doing these tests. How valuable are they? And very few of them are foolproof. From this slide you will see that the normal values have what's called a reference range. In other words, this is the range in which we think probably 95% of the normal population will 95% of the normal population will be found. If you look at the glucose levels, you'll see there's an approximate range over there. And for these liver function tests, you'll see there's an approximate range over there. When we do these tests, we need to understand what the benefits of these tests are. Thank you. Let's look at the next one. Okay. When we look at these tests, what we want to say to ourselves, how good are the tests? How helpful are they? And we come up against two terms. SN stands for sensitivity, and SP stands for specificity. And these are two important concepts to understand with regard to any medical test that is done. The sensitivity, as you'll see in the top of this diagram, is the ability, tells you about the ability of the test to pick up the people who have the illness that we're looking for. And so the sensitivity of a test tells us how good is this test in determining whether this individual has the illness that we are screening for. The second concept here below that is specificity. The specificity of a test tells us how good the test is in identifying those people who are healthy who do not have the illness that we are looking for. And the combination of these two gives us some idea of the value of these tests. In a screening test, we want a test which is highly sensitive, which is going to pick up a large number of the people who have the illness we're looking for. And specificity, also with screening tests, we would like to have tests that are specific. In other words, that we don't label healthy people with having an illness that they don't really have. Thank you. So these two concepts are important. We can continue now. Okay. One of the examples of doing tests is when we look at exercise ECGs, something like that. Let's just have the whole of this slide, please. Okay. So, when we do screening exercise ECGs, an average exercise ECG, and this is one done on a treadmill, has only about an 80% accuracy. In other words, its sensitivity is approximately 80%, which means that you're going to have 20% false positives. In other words, 1 in 5 people in the general population will be labeled as having an abnormal ECG when in fact they don't have heart disease, if you are looking at a general population. So, when we're making evidence-based decisions, we need to select the people who have an increased likelihood of illness, and by doing that, and we do the appropriate screening test, we'll get a better idea and take the gamble out of underwriting. Thank you.